So, Dr. Asad, should I start?
Yeah, I think it's 2:30. You can make a start.
Sure. Assalamu alaikum. My name is Kiran Amir and I'm the Director of Operations at Parsa Echo Pakistan Super Hub. I would like to welcome you all to the third Echo session in series of Digestive Disease Echo. It's in collaboration with Ryzik Foundation, and we are thankful to Gets Pharma for unrestricted educational grant. Today's session is organized specially for the upcoming World Inflammatory Bowel Disease Day 2022 on 19th May in collaboration with SAIA, South Asian IBD Alliance. Our expert for today's session is Dr. Shanil Kadir and special guest expert Tina Aswani Prakash. Before I introduce to our expert and guest for today's session, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any patient or individual. For maintaining discipline, you all are muted, but we do encourage participation, so you can unmute yourself for question or use the raised hand option or chat box. By participating, you have given the consent for recording, and the recorded session will be available on our YouTube channel. Link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the CME opportunities. For the convenience of the spoke, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. Our expert for today's session is Dr. Shanil Kadir, is a consultant gastroenterologist, Liaquat National Hospital, Karachi. And Tina is a patient advocate of IBD. She is founder of IBD and SAIA, and very keen to break the IBD taboos in South Asia patient and improve IBD care in South Asia. I will now hand over to Dr. Asad for further introductions of the guest and the topics. Dr. Asad.
Assalamu alaikum, everybody. It's a great pleasure to be here, and for a change, we have been moving from liver to other parts of what I would say the gut. Inflammatory bowel disease is a very important topic, and I really look forward to Shanil teaching us about the situation in Pakistan. It's not something that we can cover in one single talk. I think it will go on, and we are really working hard to design a regular inflammatory bowel disease echo session program so that we can, reach out to primary care physicians, making them more aware about this in their usual clinical practice. And it will be a great service to the people of Pakistan. Before we start, I'm honored that Tina is here from SAIA. And it's very early in the morning, I think, where she's joining, if I'm correct. So, Tina, I would love to hear from you about the introduction of SAIA and about inflammatory bowel disease, about your vision. So you have around 3 to 5 minutes before we request Dr. Kadir to start his talk. So please, if you can unmute yourself and tell us about yourself, your organization, your program, and what do you foresee for us in South Asia, please?
Sure. Assalamu alaikum. My name is Tina Aswani Prakash. Thank you so much for having me here, Dr. Chaudhary. I am one of the co-founders of South Asian IBD Alliance, as was mentioned. IBD is a topic that's very, very close to my heart. Why is that the case? My family has had IBD for a few generations now. So I myself have Crohn's disease from the last 16 years. So 16 सालों से Crohn's disease है मुझे और मेरी family में मेरे father को Crohn's disease था और he died at the age of 39 in New York at Mount Sinai Hospital. His sister also died at the age of 42 in New Delhi. My family is actually from Karachi. We are Sindhi originally, and my great aunt, meaning the buaji of my father, also passed away from what we think may have been IBD. She had bled to death in the 1930s in Karachi. So this is a topic very, very close to my heart. My family has been struggling for many, many decades with this disease without proper treatment. I'm the first person after so many years to get proper treatment. It has taken lives in my family and has really affected my childhood. This is very important to me because we have been hearing in India, Pakistan, all over South Asia, Nepal, Maldives, Sri Lanka, Bangladesh, Bhutan, and Afghanistan, that IBD is expanding. It is growing at huge numbers. और हमारे पास दवाइयों की कमी है और हमारे पास ट्रीटमेंट की कमी है और scans, colonoscopy का knowledge नहीं है. तो what we are doing as part of SIA, we have a Facebook community and we are working with patients, helping them navigate their disease, understand their disease, understand treatment options, and understand how to seek the care that they need. Also, we are referring patients to doctors, telling them to ask their doctors for the right treatment options, get the second opinion if they need to, or go from primary care to gastroenterology right away. So this is what we are doing within SIA. We are working on patient education, but also professional education like we are today. But also part of our vision is research. Making sure that there is appropriate research done in our South Asian community, because right now, most of the research being done is on white, Jewish, Scandinavian populations in IBD. However, India is right behind the United States in numbers of IBD, which is appalling. And so being that India is such a high number, what about the rest of the region? That's why we're here today. I'm here with Dr. Shanil Kadir, and I am, a patient since so many years. I've suffered incredibly. Just to give you a little bit of background on my disease, since age 22 with this disease, and I was originally diagnosed with ulcerative colitis, very, very mild ulcerative colitis. They had seen only in my colon this disease. It turned out that it was actually Crohn's disease. So I had developed complications, and I'm sure Dr. Shanil will go over this, but I had developed severe complications, granulomas, fistulas, all sorts of hallmark presentation of Crohn's disease. But what had happened is I had already had surgery for ulcerative colitis. I already had an ostomy and then was given a J pouch at the age of 24. मुझे बोला गया था कि मेरी शादी नहीं होगी ostomy bag के साथ और J pouch के साथ शादी हो सकती है अगर मैं ठीक हो जाऊं, पर मैं ठीक नहीं हुई. I did not get better with the J pouch. मुझे inflammation हो गई J pouch में और J pouch से fistula बन गए और granulomas भी बन गए. So my diagnosis was changed to Crohn's disease. There are biological therapies, advanced therapies to treat this, but those did not work on me. बहुत मेरी family ने बहुत बोला naturopathy, Ayurveda, homeopathy try करो, ये biologics नहीं मत लो, बहुत side effects हैं. So my treatment got very delayed. I kept getting sicker and sicker. So this was a very big problem in my care. Maybe B surgeries हुई हैं, at least 20 surgeries. And in that time, I have had multiple abscesses, fistulas, and finally we got a biological therapy to start working in 2015. And since 2016, मैं ठीक हूँ, remission में हूँ, but I live with an ostomy bag. मेरी शादी हुई है पर बहुत तकलीफ से. So it's बहुत stigma है, बहुत taboo है हमारी community में. पर मेरा goal है कि लोग IBD के साथ खुश रहे, like that people with IBD can still live a happy life and a fulfilling life, be able to get married, be able to work, and be able to do the things that they enjoy the most. So that's why I'm here today. Thank you for having me here. And Dr. Kadir, if you would like to kick us off with the IBD presentation, I would appreciate that. Happy World IBD Day.
Thank you. Thank you very much, Tina. And it's really remarkable. And we stand with you. And inshallah, we'll see that, we really make a difference here. So Dr. Kadir is ready. Shanil, please.
Thank you very much. Can everybody hear me? Yeah.
Yes, we
Okay.
hear you.
Yeah.
Yes,
Thank you very much. Thank you, Tina, and thank you, Dr. Asad, for inviting me. So what we are, my name is Dr. Shanil Kadir. I'm a gastroenterologist at Yarkand National Hospital in Karachi. So today we are going to talk about inflammatory bowel disease. This session, as you have already attended, if you have already attended previous echo sessions, is basically aimed for general physicians and general practitioners to make them aware कि IBD क्या है और उसमें क्या-क्या चीज़ें हो सकती हैं, एंड स्पेशली जैसे टीना ने अभी आपको बताया कि व्हेन टू रेफर द पेशेंट। मोस्टली हमारे पास पेशेंट्स जो आते हैं, आई एम श्योर डॉक्टर अल्ताफ आलम भी हैं और डॉक्टर असाद भी हैं, they come in when they've gone through many months of treatment without any relief, और फिर उनको कोई स्पेशलिस्ट को रेफर किया जाता है और फिर जो है वो IBD डायग्नोस होता है. So that what we want to cut down. If you suspect IBD, when to refer and refer early. So just gonna start with my talk. So today's talk, I'm very glad that Parsa Trust and South Asian IBD Alliance are collaborating. So this is the first of many, I hope. So first collaboration between both of them. As Tina had mentioned, there is World IBD Day on the 19th of May. And we try to make it interactive. If anything you don't understand, I would be very happy to answer the questions. So sir, first to start off with, what is IBD? Inflammatory bowel disease क्या है? So inflammatory bowel disease, अगर हम definition देखें तो it is divided into two parts, Crohn's disease and ulcerative colitis, and it is an immune mediated. So important thing is immune mediated chronic inflammatory disorder. So chronic होता है, acute नहीं होता. ज़्यादातर जैसे हमारे पास डायरिया के साथ पेशेंट आते हैं, उनको acute illness होती है. So this is a chronic inflammatory disorder, which is the key that you need to take a proper history. I know कि general practice में बहुत दफ़ा patients are too many and we don't give enough time to the patients, but that's the key. आपने patient से history जो है वो सही लेनी है कि जो उनके symptoms हो रहे हैं, are they going on for a short period of time or are they going on for a long period of time? And why do we need to bother about it? The reason we need to bother about it is because, as Tina had already shared her story, this is a progressive illness. This can cause disability. This can cause significant impact on quality of life. And in Pakistan, obviously, also in US, where healthcare is not free of cost, it can cause a very high financial burden. So जितना delayed diagnosis होगा, उतना obviously patient की quality of life पे affect होगा और financially patient burden जो है वो increase होगा. And obviously it affects younger population. So one of the drawback with the younger population is that most of the younger population, they don't bother. उनको symptoms होते रहते हैं, they just take antibiotics or something, and then they will just go on with their life. So we need to educate them. Okay, if you are getting these symptoms, go and see your general practitioner, go and see a specialist. Don't sit at home with these symptoms. Simpler definition है कि it's a group of intestinal disorder that causes prolonged inflammation of the digestive tract. As I mentioned, it includes ulcerative colitis and Crohn's disease. पहले ulcerative colitis को ले लेते हैं. What is ulcerative colitis? From the general practitioner point of view, it is, again, as I said, these are chronic inflammatory disease. Ulcerative colitis में usually there is mucosal inflammation. I'm sure अगर आप अपनी anatomy वगैरह याद करें तो mucosa, submucosa, इस तरह की layers होती हैं. तो ulcerative colitis only involves the superficial layer, which is the mucosal layer. Mostly it's limited to large bowel. तो small bowel में usually नहीं होता. mostly limited to the large bowel. There is usually a abrupt demarcation when we do an endoscopy between an inflamed part and a non-inflamed part. कभी कभी आपने ऐसे फॉलो अप पे पेशेंट्स जनरल प्रैक्टिशनर्स में देखा हो कि लेफ्ट साइडेड कोलाइटिस है या प्रोक्टाइटिस है या प्रोक्टोसिग्मोइडाइटिस है, तो दैट इन्वॉल्व्स वी दैट इज indicating that this involves only this part of the large bowel and the rest of the large bowel is all clear. What about Crohn's disease? There's a lot of overlap between these conditions. As you know, a good example was, Tina mentioned when she was initially diagnosed with ulcerative colitis, and then in the end it turned out to be Crohn's disease. So initially, there is sometimes it's a bit tricky to sort of differentiate. Crohn's disease can affect any part of GI tract, even आपके small bowel में भी हो सकती है. कुछ लोगों को upper GI Crohn's होती है कि small bowel में Crohn's है. Or inflammation usually is transmural. It involves all the layers of the bowel. तो जैसे ulcerative colitis था उसमें सिर्फ superficial layer involved थी, इसमें पूरा का पूरा bowel की layers involved होती हैं. It appears in patches and usually involves terminal ileum and distal ileum. ज़्यादातर terminal और distal ileum में होता है. इसके अलावा जैसे मैंने कहा कि कभी कभी पेशेंट्स को अपर GI Crohn's भी होती है, तो इट कैन इन्वॉल्व एनी पार्ट ऑफ द GI tract. थोड़ा सा डायग्रामेटिक डिस्क्रिप्शन आपको दिखा दूं. जैसे हेल्दी बावल है, एज आई मेंशन, Crohn disease can involve the whole thickness, so that can cause muscle hypertrophy, it can cause fissures, cobblestone appearance. लेकिन अगर आप देखें तो ये it's involving the whole of the mucosa. And with ulcerative colitis, ulceration is only within the mucosa. And again, just to reinforce that Crohn's disease affects any part of the GI tract, inflammation is transmural, ulcerative colitis only affects the large bowel, and mucosa and submucosal layers are affected. What about the causes? As with a lot of inflammatory diseases, nobody knows the exact cause. कि होता क्यों है? There are a lot of factors involved. Some people say it can be genetic factors, it can be intestinal barrier factors, it can be immune response, different immune response, it can be environmental factors. Smoking, we know, can increase the risk of inflammatory bowel disease in patients, and it can be combination of all. And why do we say combination of all? अगर आप देखें कि if you are living in Pakistan or South Asia and you move over to US or North America or Europe, we have seen a lot of patients who develop Crohn's disease after a period of time staying and living in the northern in those part of the country. So clearly there is some environmental factor as well. Obviously there is genetic or intestinal barrier and immune response, but there is clearly an environmental factor as well. But unfortunately, I think it's not only in North America and Europe, it's also increasing in South Asian countries as well, which is what I'm going to show you here. So अगर आप देखें तो ये रेड है, ये बिल्कुल जैसे अमेरिका और यूरोप वगैरह कंट्रीज में हाई इंसिडेंस है और पाकिस्तान और साउथ एशिया में लो है. लेकिन देयर इज टू थिंग्स. वन थिंग इज के एक तो the prevalence is increasing, and I'm sure a lot of GPs who are with us would agree कि ज़्यादा हम पेशेंट देख रहे हैं Crohn's disease के. पहले एक OPD में कोई भी हफ्ते में एक पेशेंट आता था, अब हर OPD में एक या दो पेशेंट आते हैं inflammatory bowel disease के. So the incidence is increasing. Whether it's increasing because our lifestyle is changed, whether it's increasing because people are more aware, I don't know. The issue is कि हमारे पास कोई डेटा नहीं है. बाहर मुल्कों में तो because it's been there for a long time and research होती रहती है, तो उनके पास a lot of data about their inflammatory bowel disease patients. हमारे पास कोई डेटा नहीं है inflammatory bowel disease patients का, which is something that we need to work on. Secondly, pediatric population में भी inflammatory bowel disease आहिस्ता आहिस्ता बढ़ रही है, which is very important. Young बच्चे हैं as I said, inflammatory bowel disease can cause a lot of disabling symptoms and financial problems, and जैसे टीना ने socio-economic problems mention किए, so it can cause a lot of those, and especially in children, you need to support the child, you need to support their parents. वो भी worried होते हैं कि ये क्या हो रहा है इसको, बच्चे को नहीं पता होता. तो the fact that it's increasing in pediatric population means that we need to get our act together and we need to start thinking about inflammatory bowel disease. Incident in South Asia, कोई ऐसा स्टडी प्रॉपर स्टडी नहीं है इंसिडेंट का, लेकिन ये 2012 2013 की स्टडी 2020 ये रिसेंटली स्टडी पब्लिश हुई है जिसमें पुराना डेटा है, एंड यू कैन सी दिस इज पर 1 लाख पॉपुलेशन. सो द इंसिडेंट्स इज चाइना से कंपेयर करें तो इंडिया में इंसिडेंट ज़्यादा है, which is I'm sure it's similar in Pakistan and Bangladesh and all the South Asian countries. But as I said कि हमारे पास we don't have enough data from Pakistan to say कि हमारे पास कितना इसका incidence है. What about epidemiology? So usually happens, peak age of onset is between 15 to 30 years. There is a second peak between 60 to 80 years. For ulcerative colitis, the male to female ratio is 1:1. For Crohn's disease, it's 1.1 to 1.8. As I mentioned, smoking increases the risk. Also, if you have a first degree relative with inflammatory bowel disease, your risk increases by 5 to 20 folds. So इसीलिए history is important. If somebody in the family has been diagnosed with inflammatory bowel disease, then the patient that you are seeing have a low threshold for investigating them. And obviously, overall in the world over, the prevalence of inflammatory bowel disease is ever increasing. थोड़ा सा सिम्टम पे आ जाते हैं, क्योंकि obviously from the GP, general practitioners and physicians perspective, पेशेंट सिम्टम के साथ आता है. तो क्रोन्स और अल्सरेटिव कोलाइटिस के मोर और लेस सिमिलर सिम्टम्स होते हैं, कुछ थोड़े से डिफरेंट हैं, इसीलिए मैंने अलग अलग करके आपको दिखा रहा हूँ. तो मोस्टली पेशेंट प्रेजेंट होंगे इन क्रोन्स डिजीज विल प्रेजेंट विद डायरिया, ब्लीडिंग थ्रू द बॉटम एंड जब स्टूल पास करते हैं. इसके अलावा फीवर, इसके अलावा वेट लॉस, लॉस ऑफ एपेटाइट, क्योंकि मेल नरिशमेंट होती है, वो स्मॉल बाउल को इन्वॉल्व करती है, तो मेल नरिशमेंट होती है, तो वो काफ़ी अरसे से उनको इस तरह के सिम्टम्स होते रहते हैं. इसके अलावा एक्स्ट्रा इंटेस्टाइनल सिम्टम्स भी होते हैं कि इन्फ्लेमेशन ऑफ द आइज हो जाती है, माउथ अल्सर्स होते हैं, जॉइंट पेन्स होते हैं या जॉइंट स्वेलिंग होती है. तो ये सारी चीज़ें क्रोन्स डिजीज़ में हो सकती हैं. लेकिन मोस्टली जैसे आपको प्रेजेंट करेंगे पेशेंट, तो वही ब्लडी डायरिया होगा, या इवन ब्लडी डायरिया नहीं भी हो तो डायरिया है विद म्यूकस है, हिस्ट्री ऑफ वेट लॉस एंड सिम्टम्स ऑफ से चल रहे हैं, इधर उधर एंटीबायोटिक ले लिया बट दे आर नॉट गेटिंग बेटर. What about ulcerative colitis? So again, similar sort of symptoms. वही चीज़ें है, ब्लडी स्टूल है, डायरिया है, पेन है, एब्डोमिनल पेन है, इंक्रीज अर्जेंसी है. यूजुअली अगर अल्सरेटिव कोलाइटिस नीचे के पार्ट को इन्वॉल्व करता है, रेक्टम और सिग्मोइड को इन्वॉल्व करता है या रेक्टम को इन्वॉल्व करता है, तो पेशेंट को अर्जेंसी होती है, बार बार स्टूल आना, बार बार फीलिंग होना कि मुझे स्टूल आ रहा है, लेकिन कभी स्टूल आता है, कभी नहीं आता, कभी कुछ भी नहीं आता. Weight loss and obviously chronic fatigue, nutritional deficiencies, or joint pains or inflammation of eye, और ये सारी चीज़ें ulcerative colitis में भी वैसे ही होती हैं जैसे Crohn's disease. From the GP's perspective, जब आप पेशेंट को देख रहे हैं तो क्या क्या चीज़ें आपको मिल सकती हैं. मेन चीज़ जैसे मैंने कहा, एब्डोमिनल पेन, डायरिया, फीवर, रेक्टल ब्लीडिंग, वेट लॉस की हिस्ट्री होगी, एनोरेक्सिया एंड नोजिया. कभी कभी एब्डोमेन में टेंडरनेस भी मिल सकती है, कोई पैल्पेबल मास मिल सकता है कि अगर लॉन्ग स्टैंडिंग डिजीज़ है तो हो सकता है कि पैल्पेबल मास मिल जाए आपको. माउथ, स्किन, आइज, जॉइंट, लिवर, ये एक्स्ट्रा इंटेस्टाइनल मैनिफेस्टेशंस हैं, इसके आपको सिम्टम्स मिल सकते हैं. माउथ अल्सर्स, जॉइंट पेन, आई सिम्टम्स. और लेबॉर्ट्री फाइंडिंग में बेसिक चीज़ें हैं जैसे पेशेंट एनीमिक हो और वाइट सेल काउंट रेज हो, CRP, ESR रेज हो. यूजुअली आई टेंड टू प्रेफर CRP, क्योंकि ESR तो पाकिस्तान में आई एम श्योर हर किसी का रेज होता है, तो CRP इज आई गेस के आई थिंक इज मच बेटर देन ESR. स्टूल में FOB पॉजिटिव आता है, ठीक है। स्मॉल बाउल डिजीज जिनको होती है उनको फिस्टुला या स्ट्रिक्चर्स बनते हैं, वॉमिटिंग के सिम्टम्स होंगे, सिवियर एब्डोमिनल पेन के सिम्टम्स होंगे। तो दीज आर द फ्यू थिंग्स दैट जब आप पेशेंट को देख रहे हो अपनी सर्जरी में या प्रैक्टिस में, तो उनसे आप जो है ऑन द स्पॉट आप ये चीज़ें जो है नोटिस कर सकते हैं अलॉन्ग विद द सिम्टम्स। व्हाट अबाउट द डायग्नोसिस? तो डायग्नोसिस ऑब्वियसली गुड हिस्ट्री। आई एम श्योर हर किसी, जब भी हम मेडिसिन करते थे, मुझे याद है 3rd ईयर 4th ईयर में, तो हमें यही सिखाया जाता था कि हिस्ट्री अच्छी लो, हिस्ट्री अच्छी लो, हिस्ट्री अच्छी लो। एंड इवन दो वी हैव अ लॉट ऑफ good the medicine has progressed since when I did my MBBS and other people did their MBBS, still a good history is very important. कि आपने history जो है वो आपने if you ask a lot of the questions and the diagnosis and the differential diagnosis come out with a good history. इसके अलावा फिर रूटीन ब्लड टेस्ट, हर कोई पेशेंट का CBC तो पहले से हुआ होता है, तो इसमें आयरन डेफिशिएंसी एनीमिया हो सकता है, लो B12 हो सकता है, ESR CRP रेज हो सकता है, ठीक है। अगर तो इन्वॉल्वमेंट ऑफ द लिवर है तो LFTs ख़राब हो सकते हैं, लो एल्बुमिन, सीरम एल्बुमिन लो हो सकता है विच इंडिकेट्स मेल नरिशमेंट। तो ये सारे सिंपल से टेस्ट हैं जो कि आप अपनी प्रैक्टिस में करा सकते हैं, जस्ट टू गिव यू एन इंडिकेशन वेदर the patient has inflammatory bowel disease या just sort of a differential diagnosis. इसके अलावा फिर रूल आउट अदर कॉजेज। डायरिया के बहुत सारे कॉजेज होते हैं। पाकिस्तान, साउथ एशिया में मेन कॉज है ट्यूबरक्लोसिस, तो मेक श्योर कि यू रूल्ड आउट ट्यूबरक्लोसिस। कभी कभी इट्स वेरी डिफिकल्ट टू डिफ्रेंशिएट के पेशेंट को ट्यूबरक्लोसिस है या पेशेंट को इन्फ्लेमेटरी बाउल डिजीज है। एंड आई वुड सजेस्ट कि अगर आपको इस तरह लग रहा है तो इट्स बेटर टू रेफर द पेशेंट टू द स्पेशलिस्ट रादर देन आप उनको एंटी ट्यूबरकुलोसिस मेडिकेशन शुरू करें और फिर 2-3 महीने के बाद फिर भी सिम्टम्स उनके वैसे के वैसे हैं और फिर बंद कर दें कि भाई TB नहीं था और अब नाउ वी नीड टू लुक एट इन्फ्लेमेटरी बाउल डिजीज। इट्स बेटर टू जस्ट रेफर द पेशेंट टू द स्पेशलिस्ट, ताकि वो उनका जो टाइम पीरियड इतने महीने वो अननेसेसरी मेडिकेशन अगर ले रहे हैं तो वो उनका बच जाए, उनका डायग्नोसिस जो है वो जल्दी हो जाए। एक चीज़ जो मैंने देखी है जो कि हम लोग बहुत कंजूसी करते हैं और we don't do it too much is a stool test. I don't know why everybody who comes with diarrhea, we just give them antibiotics and nobody bothers about sending in a stool test. The stool test is very important. All you have to do is just tell the patient कि एक stool test आप करवा लें. It's okay if you think that it's an infective diarrhea. You can still give antibiotic according to what you feel clinical practice में कि क्या है patient को. But there is no harm sending a stool DR or a stool CS just to make sure कि भाई कोई और चीज़ तो नहीं है, especially in patients whose diarrhea is not settling down with simple antibiotics. The second thing which I've mentioned here is please don't send stool for H. pylori in these patients. These are not symptoms. This is not related to H. pylori. H. pylori has got nothing to do with this. So don't send stool for H. pylori in this patient. If you do have to send a stool sample, stool for DR and CS. And if you suspect, there is a stool test called fecal calprotectin, which you can send off patient को। वो इसी तरह stool sample होता है। पाकिस्तान में डाओ लैब करती है, आगा खान करती है, आई एम श्योर और भी बहुत सारी लैब्स हैं जो कि फीकल कैलप्रोटेक्टिन का टेस्ट करती हैं। तो इफ इट्स अवेलेबल आप भेज सकते हैं, बट as I was said in the last bit here, please refer the patient to the specialist. अगर आपको लग रहा है थोड़ा सा भी आपको लग रहा है कि this patient could have a inflammatory bowel disease, don't wait, please refer the patient. The patient आपको दवाई देंगे बाद में कि because डॉक्टर साहब ने हमें proper refer किया and we got a proper treatment. Investigation, when patient comes to us, now these investigations are usually done by a specialist, and I've not gone into detail because obviously we are just giving you a flare of the inflammatory bowel disease. So simple investigation like abdominal X-ray, we look for any toxic megacolon, we look for constipation. A lot of patients, these patients have right-sided fecal loading and constipation. Patients who present with abdominal pain, if they are known to have IBD, they can present with toxic megacolon. Sometimes that's the first presentation. They are not known to have IBD और एकदम से जो है वो abdominal symptoms और abdominal obstruction, intestinal obstruction के साथ present करते हैं. The next, sometimes people do barium studies, although in this age, barium studies are rarely used. So we usually go for a CT or MRI scan. The problem with MRI scan is overseas it's very good, but in Pakistan, MR small bowel is not very frequently available. Not every radiologist can read MR small bowel. So whenever I have requested an MR small bowel in inflammatory bowel disease patients, it usually comes back आप CT करा लें क्योंकि MR we don't have that facility to look at it and report it properly. So CT scan is okay as well. Look at your limitation. आप जहाँ पे भी काम कर रहे हैं आपकी obviously हर जगह सारी facilities नहीं provide होती, तो जहाँ पे आपकी जो facilities हैं you can sort of tailor your investigation according to the locality and the place where you're working. Ultrasound abdomen, बाहर मुल्कों में तो there's increasing use of ultrasound abdomen in patients with confirmed IBD to look for whether the medications are helping and whether there's any healing or not. In Pakistan, obviously, I don't think we have the expertise to look at inflammatory bowel disease with ultrasound abdomen. And the gold standard है colonoscopy or sigmoidoscopy, depending on sometimes patient with present with a severe illness, and we just, when we go in with a scope, we just do a sigmoidoscopy rather than a colonoscopy because the risk of perforation is high. And sometimes if the patient is not admitted with severe disease, जैसे outpatient होते हैं, so the gold standard is basically colonoscopy, where we go into the small bowel terminal ileum, we take biopsies, we look at the mucosa, and this is the picture. So if you look at Crohn's disease and ulcerative colitis, so this is the Crohn's disease, this is ulcerative colitis. So we have some sort of scoring system जो कि हम अपने लिए करते हैं जब हम colonoscopy patients की करते हैं देखने के लिए. You can see कि Crohn's disease में ulceration होती है, फिर ulcerative surface expand होता रहता है, उसके बाद फिर जो है narrowing, luminal narrowing हो जाती है, और ये फिर पूरा narrowed हो जाता है. And when it becomes this narrowed, the patient presents with severe abdominal pain, intestinal obstruction के साथ symptoms जो हैं वो उसके होते हैं. इसी तरह ulcerative colitis में भी this is the normal mucosa, आप देख सकते हैं कि pinkish है, there is blood vessels visible, the folds are visible. Sometimes there are subtle changes के loss of blood vessels हो गई, ठीक है, loss of mucosal fold हो गए, बिल्कुल blank mucosa हो गया. And then the disease severity can increase, so patients can have erythema, fragility के scope touch करने से या patient का bleeding हो, and then severe ulceration and spontaneous bleeding के जैसे आपने scope डाला तो वो bleeding होगी. So this just sort of gives us an idea about the severity of the ulcer of the disease. And अगर आप अपनी endoscopy report पे कभी देखें कि Mayo score हुआ है या Crohn's disease का score हुआ है, तो that is just हमें अपने लिए हम करते हैं ताकि जब हम फ्यूचर में पेशेंट को फॉलो अप करें तो हमें ये पता हो कि पेशेंट का Mayo score 3 था, Mayo score 1 हो गया है या Mayo score 0 हो गया है, तो वो just for our benefit, so that we know that treatment is working. हिस्टोलॉजी में इतना ज़्यादा मैं नहीं जाऊँगा क्योंकि ऑब्वियसली आप लोगों के पास इतनी ज़्यादा हिस्टोलॉजी पेशेंट्स की हिस्टोलॉजी आएगी नहीं. तो बेसिकली वही है, अल्सरेटिव कोलाइटिस, म्यूकोसल इन्फ्लेमेशन, you get crypt abscesses, you get absent of granuloma. In Crohn's disease, it's usually transmural inflammation. The crypt abscesses are very few, but there will be a lot of granulomas, and there'll be fissuring. So yeah, obviously when we get the histology report, this sort of lets us towards the diagnosis of ulcerative colitis or Crohn's disease, and obviously the histopathologists also look through these things to differentiate the history and endoscopic finding to see whether the patient has ulcerative colitis or Crohn's disease. A simpler diagram, मेन चीज़ें जो हम देखते हैं अपने हिस्टोलॉजी में, गॉबलेट सेट डिप्लीशन है जो कि Crohn's disease में होती है, अल्सरेटिव कोलाइटिस में होती है, क्रोन्स में नहीं होती। क्रिप्ट एब्सेसिस जो हैं वो अगेन कॉमन इन अल्सरेटिव कोलाइटिस। इसके अलावा जो है वो म्यूकोसल थिकनिंग है अल्सरेटिव कोलाइटिस में, इसमें क्रोन्स डिजीज में नहीं होती। पैची लिम्फोसाइट इन्फिल्ट्रेशन होती है क्रोन्स में, इसमें यूनिफॉर्म होती है। तो दीज आर सम हिस्टोलॉजी चेंजेस जो कि हमारे हिस्टोपैथोलॉजिस्ट जब वो करते हैं, बायोप्सी की सैंपल देखते हैं, तो then they sort of, it helps them make a diagnosis whether the patient has Crohn's disease or ulcerative colitis. What about extra intestinal manifestation? You know, sometimes these patients may not present with abdominal symptoms. Yeah, abdominal symptoms might not be predominant. They may have other symptoms, you know, things like episcleritis, you know, things like aphthous ulcers. They may have renal stones presented with renal stones or joint problems. They may have skin lesions. You know, a lot of inflammatory bowel disease patients have skin lesions which they present with, and उसके बाद फिर पता चलता है कि यार आप history लेते हैं तो फिर then you find out that, you know, patient has diarrhea as well, and it might be Crohn's disease. So look for other extra intestinal manifestations along with the main symptoms of inflammatory bowel disease. Skin manifestations. यूजुअली जनरल प्रैक्टिस में स्किन मैनिफेस्टेशंस मेरे ख्याल से पेशेंट्स हैं वो पहले जीपी के पास ही आते हैं अगर कोई स्किन रैश वगैरह होता है तो बी वेयर ऑफ स्किन मैनिफेस्टेशंस ऑफ inflammatory bowel disease. There are quite a few. I'm not going to go into detail of them, but you know, this is just to make you aware that inflammatory bowel disease can have skin manifestations, and these might be the symptoms that patients present to you with. What about management? Firstly and importantly, rule out other causes. Pakistan में और South Asia में especially tuberculosis is very common. So firstly, make sure you've ruled out tuberculosis. As I said earlier on, you know, if you are unsure, it's better to refer the patients. Once you've made a differential, you know, this patient could have inflammatory bowel disease or could have tuberculosis, just don't sit on the patient, just refer the patient. The patient will be coming back to you because obviously once he's had a treatment in the specialist center, you are the person who's going to follow them up in the community. Lekin ye don't sit on them. Just refer the patients so that they get early diagnosis and we can save them from complications. Initial management जो हम दवाइयाँ इसमें यूज़ करते हैं, इसमें 5 ASAs यूज़ करते हैं जो कि मिस्टालाजीन के नाम से आती है पाकिस्तान में. Steroids यूज़ करते हैं to dampen the acute inflammation. One thing about steroid is that I'm sure everybody knows the long-term side effect of steroid. A lot of patients with inflammatory bowel disease that I see, they've been on steroids for 2 साल से steroid पे हैं, 3 साल से steroid पे हैं. Nobody's ever bothered to think about that patient is having a lot of steroid for a long time. We need to think about immunomodulators या दूसरी medication ताकि steroid को हम stop कर सकें. So you know, if you are putting somebody on steroid, that is your responsibility to make sure that the patient is not taking steroid lifelong. You know, you need to, obviously it's the responsibility of the patient to come back to you as well, but it's also your responsibility to guide the patient कि ये steroid जो आपको treatment दी जा रही है ये सारी ज़िंदगी के लिए नहीं है. You need to come and see me after this many months or this many weeks, and we are tapering down your steroids, and if the symptoms are not getting better, we need to think about something else. So make sure you look into the steroid. Other medications जो commonly use होती हैं, azathioprine, methotrexate, tofacitinib जो है वो पाकिस्तान में available नहीं है, लेकिन usually azathioprine is very common, तो वो हम use करते हैं. Methotrexate भी available है, but most of our patients do, for some reason, do quite well if they are on enough dose of azathioprine. And then biological therapy, anti-TNF, and lastly, some patients can present with surgery, present with an acute abdominal symptoms and end up having surgery as well. So this is a disease pyramid of inflammatory bowel disease. So mild symptoms में usually topical, depending on के कहाँ पे symptoms हैं. अगर local हैं तो topical steroid भी दिया जा सकते हैं, antibiotics and 5 ASAs, and then in patients with moderate symptoms, Then we think about oral steroid immunomodulators, and then obviously if they are not responding, if they are refractory, then we think about biological therapy and surgery. So biological therapy, there's a lot of biological agents, adalimumab, infliximab, vedolizumab, but unfortunately Pakistan mein sirf infliximab is available. The other medications are not available. Immunomodulators, as I mentioned, we have azathioprine, we have methotrexate, cyclosporin is also available, but थोड़ी सी tricky होती है to get it, but in some places it is available. And obviously steroids, budesonide, prednisolone. Again, our drawback is in Pakistan, budesonide is not available. We only have prednisolone. So, dalta-cotyl, जिसको आप कहते हैं, that's the only steroid which is available. And obviously, 5-ASAs and antibiotics are commonly available. So this is a disease. This is the treatment pyramid. So we do just like a step-by-step approach होती है. So we start patients on if they have a mild symptoms on these, and then we go up. Sometimes, we do a top-down approach. Okay, अगर patient को symptoms हो रहे हैं, we start them on immunomodulators and instead of just going from the bottom end. So it depends on severity of the symptoms. It depends on response. It depends on the severity of the disease. So we can sort of tailor the treatment accordingly. 5-ASAs basically, they are anti-inflammatory. Steroids, you also know, they are also anti-inflammatory. Immunomodulators, just azathioprine होते हैं, they basically suppress your immune system. Patients do have increased risk of infection, but not that much. And obviously, they just need to take care if they have sore throat and things like that. They need to get in touch with the GPs or their specialist. Antibiotics, sometimes, patients with ulcerative colitis and Crohn's disease are prone to getting infection, and antibiotics are used to prevent and control the infection. And obviously, biological treatment is when everything is not working and patients are steroid dependent, and then we think about going towards biological treatment. And as I mentioned, these are all the biologicals which are available. Unfortunately, in Pakistan, we only have infliximab. We are hoping that in the future we may have other biological treatments available in Pakistan, but at present, infliximab is the only thing which is available. This is just a chart showing options for treatment for Crohn's disease and ulcerative colitis. It's basically, just to show you that treatment is not very simple and straightforward. We go back and forth between medications. Think about surgery. Think about these people can be on and off steroids. They can be on anti-TNF. They can be on immunomodulators. So the treatment is sort of quite complex and is tailored according to the patient. One treatment may not fit all the patients, but the key is, if you refer these patients early, अगर आपको लग रहा है कि patient को inflammatory bowel disease हो सकती है, तो refer them early so that we start their treatment early so that they don't have any problems, long-term complications. There was this recent study in 2022 which showed that the ethnic minority status and socioeconomic deprivation was associated with worse surgical outcomes in our IBD patients. And this is the same in Pakistan as well. We have socioeconomic deprivation, and I'm sure, although there is no data available in Pakistan, I'm sure that if we do have a data for that, it will show that our IBD patients also have worse surgical outcome and worse medical outcome as well, because most of them don't end up seeing a specialist unless they've had complications and they've been to a hospital and then they get diagnosis of inflammatory bowel disease. Role of antibiotics. Pakistan mein, unfortunately, use of antibiotic is quite a lot. जिसको भी डायरिया होता है वो फ्लैजेल और सिप्रोफ्लॉक्सासिन तो वो खुद ही बाजार से लेके और खा लेता है. So there is this Danish study which showed that use of antibiotic was associated with increased risk in developing ulcerative colitis and Crohn's disease, and this was the risk rose with each additional dose of antibiotic. So just to sort of make you aware. I'm sure we all look at the patients and prescribe antibiotics if the patient needs it, but try and discourage regular antibiotics by the patients. We see a lot of patients in GI clinic. हमें diarrhea हुआ था, हमने 2 दिन antibiotic खा ली, then it settled down, now it's back again. So we try and discourage patients from taking antibiotics without consulting a general physician or a gastroenterologist or a doctor. Long-term complications. So long-term complications, usually malnourishment, malabsorption, people get anemic, they get perforated bowel. Sometimes that's the first presentation के hospital में perforated bowel के साथ आए हैं. Fistula and strictures, abscess, especially in Crohn's disease patients, they get all these things, especially if they're not being treated properly. They get extra intestinal manifestations, as we said, sore eyes, redness, joint swellings, and obviously they are in increased risk of colorectal cancer. So they need a colonoscopy surveillance, they need a colorectal screening surveillance, and they need regular monitoring of their bloods, especially if they're on azathioprine or if they're on antibiotics, and treatment of flare-ups, because even if they're sometimes if they're on immunomodulators and they get a flare-up, they might need to be on steroids for a short duration to dampen the flare-up. So regular monitoring usually gastroenterologists करते हैं, but obviously in places where patient come up from far off के regular उनको access नहीं हो gastroenterologist का, तो it's something that the general physicians can look into के regular bloods करा लें and think about surveillance of these patients if they've not had issues in Pakistan. So a few issues that I have noticed obviously in my practice is, firstly, there's a lack of awareness, not in general physicians only, but even on gastroenterologists. A lot of we as a gastroenterologist don't think about IBD as the first. We always think this patient's having diarrhea is probably infective diarrhea. So we need to think about inflammatory bowel disease. जब हम सोचेंगे कि भाई inflammatory bowel disease को हो सकती है, then we would pick up more patients, because the more because then you would investigate these patients accordingly. Secondly, most of the patients do doctor shopping. एक डॉक्टर दिखा दिया, अब अगर उनसे उन्होंने दवा दे दी, एक गोली ले ली, उससे बेहतर नहीं. From the patient's point of view, doctor shopping by patient is very common, and थोड़ा सा the patients. So the doctor shopping by patient is very common, and थोड़ा सा हमें patients को awareness करनी होती है कि these symptoms, you should stick with one person rather than going forward with different people. Increasing use of antibiotics, which I have already mentioned. Inflammatory bowel disease doesn't come to our mind when we see patients in clinic. Obviously, there's always a confusion that tuberculosis inflammatory bowel disease है, tuberculosis है. So lack of IBD histopathologist. A lot of the time we send a histopathologist, take a biopsy, send it to the histopathologist. Clinically and endoscopically, it looks to us कि inflammatory bowel disease है, लेकिन histopathologist doesn't agree with it. या histopathologist doesn't give us a heads up कि हाँ ये आप you are confirm नहीं करते कि हाँ सही है, ये inflammatory bowel disease है. So and we need to then, in those cases, we sometimes go and discuss it with the histopathologist again. Okay, this is the history, this is the endoscopy report, and what do you think? तो वो histopathologist हमारे पास IBD related इतने ज़्यादा नहीं है, क्योंकि obviously इतनी frequency भी नहीं थी शुरू में, तो that's why maybe they don't look into that properly. Lastly, we have problems with medication. As I mentioned, there's unavailability of medications. A lot of anti-TNF medications available नहीं है. Infliximab, it's very, very costly, considering that you have to give it every 8 weeks. One dose, as I remember, is like 60,000 rupees. So a lot of patients they don't want to have it, because they can, even if they afford one dose, they can't afford it regularly every 8 weeks. And there's a lack of patient support group, which I'm sure Tina and IBD disease are looking into it. and they have created Facebook pages so that patient get proper support and proper information. And this is a time of social media and internet. There shouldn't be any problem patient getting support from different supports which are available all over the world. IBD treatment specialist. So if I was saying कि नहीं जी IBD तो सिर्फ gastroenterologist ही है, उसके अलावा तो कुछ भी नहीं है, तो that is absolutely wrong. Everybody is part of the care in these IBD patients. So gastroenterologist, dietitian, mental health provider, primary care physicians, ophthalmologists. So it's a team effort. Everybody has their own different part to play in, and everybody has to work in a team for the benefit of the patient. And lastly, don't forget about the patient. This condition is obviously a life-changing condition. People get a lot of socioeconomic pressure. People get a lot of mental health issues with these conditions. So don't forget about the patient. Sometimes we run after numbers or disease and we ignore the patient. So when the patient with chronic illness, not with IBD, only with IBD, but all the chronic illnesses, if they come to your clinic, think about their mental health being, think about their, their work, their home stuff. You need to, although you may not be able to help it, but at least you can provide a year for them to vent their feelings and maybe provide them with support groups or something like that, so that it can help. Thank you very much.
Thank you. Thank you very much, Shanil. If you can stop here. Thank you. Excellent talk. I would go straight to Professor Altaf Alam. He's our course director and retired professor of gastroenterology and head GI department, Sheikh Zayed Hospital. I would love to take his comment. Dr. Altaf, please.
Thank you very much, Asad, Shanil, and Tina for enlightening Pakistani family physicians and gastroenterologists on this very important day. Certainly, it's a difficult chronic disease to handle, and certainly we need more than we think for the management of this particular problem. It is really a very good job that SAYA has been introduced into Pakistan, because you need more than prescriptions here. And certainly guidance, encouragement, support, just answering simple questions of the patients takes a very important role in the management of this chronic illness. I really enjoyed your talk, Shanil. You have touched upon all the basic things that we all need to know. And I thank Asad Chaudhary for organizing this on the occasion of World IBD Day. Tina, I would really appreciate if you can just in a few minutes guide us. What can you offer for our patients and how can they get in touch with you? And it will be great help for our patients. Over to Tina, please.
Absolutely. Thank you so much, Dr. Alam. So we have a Facebook community called IBD Desi's Facebook community. I'll share the link in the chat. We have about 1,150 patients already in there from around the world. Several are already from Pakistan. So we are happy to support your patients. We have several patient advocates who are guiding patients in Pakistan, in India, in US, UK, Canada, all over. We even have some patients from Maldives and from Nepal, etc., Bangladesh. So we are trying to guide as much as possible and give patients as much hope, courage, support. And I'm very glad that we've shared some links around tofacitinib and also Ramsima is a biosimilar that's now available in Pakistan for half the price of the biologic infliximab, and it's an injection form. So I just want to make providers aware of that as well. It's much easier than getting an infusion of infliximab instead of, and they can give themselves an injection, or the doctor can give injections. So that's half the price, and it looks like there's Tofa-Jack available in Pakistan for a tenth of the price of the tofacitinib. And that's also available in Pakistan, it looks like. So the medications are coming. We are guiding patients, doctors like Dr. Shanil Kadir, who that the patient has the care that they need.